So welcome back, everyone. We're gonna start very slowly here. My name is Mette Viom, and I'm here presenting this last session of today with Javier Pereira. And I think we're gonna have much fun here because this last session is full of hernia superstars presenting hot topics. So I can't wait to welcoming the first speaker here. Unfortunately, he had to leave early, so it's a recording. So I'll just ask the next presenter, Igor Belyansky, to be ready after that. Yeah. Can you put on the recordings of Johan? Of course, you all know Johan from Reims.
My first drawing is an anterior view of the abdominal wall. So the head is superiorly and the left is to the right of the screen. So I have drawn the inguinal ligament, the anterior superior iliac spine, and the inferior one, just here. So we will draw the iliopubic arch with the acetabulum, and the ischiopubic arch with the ischium and the pubis right here. Here is the obturator foramen and the pubic tubercle. The cartilage is blue on this drawing. And we will draw the linea alba, the midline of the abdominal wall, inserting in the xiphoid tubercle, and we draw here the last ribs with the last costal cartilage. The rectus abdominis muscles insert superiorly on the last cartilage rib, and we draw here this muscle. He has tendinous intersections, and here we draw the border of the muscle. He has 3 to 5 tendinous intersections, and we will draw the anterior rectus sheath only on the left side. First, the external oblique muscle, which is the most superficial muscle on the lateral muscles, and we will see it covers partially the abdominis muscle, the rectus abdominis muscle, in the superior part of the abdomen. He has a great muscular part and a great aponeurosis part, and his fibers are oblique inferiorly and internally like this. Inferiorly, he has is drilled by a wall. It is the external inguinal ring. We draw the same muscle right side, external oblique muscle, which is cut in the medial part. Here we cut this external oblique muscle, and behind we can see the internal oblique muscle. We know that this internal oblique muscle forms inferiorly the conjoint tendon. This line is the transition between the muscular part laterally and the aponeurosis part of this muscle in the middle. His fibers are oblique inferiorly and laterally, with his aponeurosis part inferiorly right here. Here is the umbilicus, and we define here the umbilical hernia. Then we will draw the last muscle. It is the transversus abdominis muscle, and here we draw the line showing the transition between the muscular part and the aponeurosis part of this muscle. Muscular part laterally and aponeurosis part of this muscle internally. So here is the umbilical ring, and on the umbilical ring are the umbilical hernias, and just superiorly are the epigastric hernia. Here you can see the drawing I performed for the guidelines with the umbilical hernias, which are defined as a hernia on the umbilical ring, and just superiorly, the epigastric hernia, from the umbilical ring until the xiphoid process. And now we will explain the Spiegelian hernia. We draw here the interspinal plane, and 6 centimeters superiorly, we can find here, which is called the Spiegelian hernia belt. And just here, we can see the Spiegelian fascia, which is limited laterally by the internal oblique muscle with its muscular part, and internally by the rectus muscle. We can draw the same fascia just here, which is called Spiegelian fascia, and the Spiegelian hernia are just here. And we can draw an axial slice through the interspinal line, and we found the rectus muscle, the anterior rectus sheath. In this location, there is no posterior rectus sheath, and we can find first the external oblique muscle with its muscular part and very large aponeurosis part. The internal oblique muscle is just here, near the rectus muscle, and the transversus abdominis muscle is here with a high aponeurosis part. And the Spiegelian hernia is here with a drill, a hole, concerning the 2 deep muscles, internal oblique and transversus. And here we can find the transversalis fascia and the peritoneum, showing the Spiegelian hernias.
Okay, only someone like Igor Belyansky can follow something like that. He's going to talk to us about the management of posterior sheath. Is closure really necessary?
All right. May I have my slides, please? Good morning. Thank you very much. Let's see. So here's a quick answer. Where we stand right now. Should we close the posterior rectus sheath or not? And the quick answer is, I'll just say, in my practice right now, I close posterior rectus sheath in all the cases, or at least I give it a good attempt. My disclosures. So, if you look 47 years ago, this is a original paper by Reeves. It's very interesting to look at the diagrams, of course, because the way I was trained to do reef stop repair, so I was always trained by my mentors to close the posterior rectus sheath, and we trained to do this open. But it's interesting to see in this paper, actually, that Reeves himself described actually either bridging the posterior layer of his peritoneum or sometimes using a mentum. And, looking at this diagram, the importance of potential closure posterior rectus sheath is not really represented here. So I want to just show the original paper. And this is more from our work with Jorge Diaz. This is ETAP axis showing what we do. So those of you not familiar with ETAP axis, we gain access to retrorectus space, and we cross over. We travel from one retrorectus space to another by incising the medial contributions posterior rectus sheath to the linea alba and traveling just posterior to linea alba. And you see in the right lower corner here, you see the cut edge posterior rectus sheath on the left side, and then a bridging peritoneum in between, and then the cut edge of posterior rectus sheath on the other side. And what we used to do in these cases, when there was bridging peritoneum, I would never reapproximate the posterior rectus sheath together, because the importance of the way we thought about it before is, we would just provide a white mesh overlap. It would restore the continuity of posterior layer. And I don't think, personally, at the time, we understood the importance of posterior rectus sheath, what provides. So this is kind of intraoperative picture, an old video probably for 7, 8 years ago. We used to do this laparoscopically. Victor Radus may show some of those images. But again, representing in real life, bridging peritoneum between left and right posterior rectus sheath. And again, this continuity is restored with a peritoneum, and there's no communication with intra-abdominal viscera, and we would place the mesh in retromuscular space here. So what happens when you divide posterior rectus sheath and you don't reload it? So this is a simple diagram, but you'll see, like, if you guys start looking at CAT scans, either TAR cases or cases where posterior rectus sheath is not reloaded, the shape of rectus abdominis muscle changes. The posterior and anterior rectus sheath, they invaginate around the rectus abdominis muscle. When you divide the posterior layer and you actually close the midline, you start looking at the rectus abdominis muscle cross sections goes from oval to becoming more like flat, like a pancake. This is a TAR case, but it's very similar. You will see in TAR cases that a lot of advancement happens from the change in the shape of rectus abdominis muscle. There is some change in the linea simularis, but really a lot of it happens, you can see it before and after cases, because you do not reload the posterior rectus sheath back on itself. You lose those posterior forces, linea simularis, invaginating around the rectus abdominis muscle. So, I'm going to present and just show you some images of before and after. This is a very simple case, and this is a cross-section through the belly button, and we are in the process of publishing this data, but shows here the width of rectus abdominis muscle before. Then, in this particular case, we did not reload the posterior rectus sheath back together, meaning we left bridging peritoneum. And you see, this is CT scan a few months later, you see the rectus abdominis, retrorectus space is now wider because the muscles flatten out, and the linea simularis actually increases in size. And so some of you guys who are doing ETAP access without reloading posterior sheath, you may notice increased bulging when it's not a hernia being back, but just increased bulging when they engage their core. And so we did not understand that in 2015 and 16 years. So what do we do now? So it completely changed things you're looking at subxiphoid space here, and here I am using a 2-0 stitch, using a horizontal mattress stitch. We do this, and this has been published before by others. I don't have a quote to show you, but it tends, this type of stitching tends to be less likely to rip through the posterior layer fascia, as opposed to whip stitching a little bit more likely to rip through. So we go from top to bottom, all the way down below the arcing line, and get this back together. If you're doing this robotically, we drop the pressure to 5 millimeters of mercury. In open cases, obviously, this is not the case. But all the cases nowadays, well, the majority of them, I do them robotically. And what happens as you pull this posterior sheath together, you reestablish those posterior forces of linea simularis, and actually you can advance and sometimes decrease the distance between linea simularis as you do the step. After the first layer, what we'll do is, you'll see me here measure the space, but I also now use a 3-0 stitch as well as smaller needle to then provide a second layer to over suture this step. Now, whether that's necessary or not, I do not know. This is more of you're hearing level 4 kind of personal opinion here. So what you do in your practice is up to you, but I also do the double layer closure here with whip stitching. So this is this step, and this is reproducible. Initially, I didn't think it was reproducible. When you do this robotically and drop the pressure, this step is reproducible almost on a consistent basis in higher BMI patients as well. Most important, one thing I want to mention is distributing the tension along the suture line. If you see vectors of forces where in one spot there's more tension, that area may come apart, especially as the patient is waking up. But this is a tension closure. Tension is our friend in hernia. It's not an enemy like we used to be taught. And so again, before and after CT scans, and now you see a little bit different. You see the rectus abdominis muscle shape is intact, and the distance between linea simularis is actually, it's more near now. Another case here, before and afterwards. And so what we're going to do, we're going to look through about 100 CT scans for before and after. We're going to report the numbers, and I don't have this for you guys. But notice the top view has the rectus space increases a little bit as even though you reload the posterior rectus sheath. So there is still some myofascial advancement, but the linea simularis distance decreases overall as opposed to what I showed you guys earlier when we did not reload. And so I think there's importance of morphology of downwall when you reload the posterior rectus sheath, and I feel like we need to be aware of this as we, as a lot of us out there still not reloading it, and they're surprised to see the bulging. So I think the reloading of posterior rectus sheath plays an important role in a function of downwall. I do think bunching up the muscles together does allow you to engage your core better. There's no data. This is, again, personal opinion. And the cosmesis also will improve with less bulging postoperatively. Thank you very much.
Questions and comments in the end?
Yeah.
Yeah, we'll do that. welcome to the stage. We have a little change here. Dr. Agustin Ignacio Alvarez Plaza. He's an abdominal wall surgeon from Chile, and he's going to tell us all about to close or not to close the defect in large inguinal hernias.
Thank you. Thank you, everyone. Thank you, Flavio. Thank you for the invitation. To solve a dilemma is really complex. Maybe, probably, I won't be able to solve a dilemma, okay? And just lower the expectation because the word dilemma is really complex. I don't have nothing to disclosure. This is a dilemma. Which came first, the chicken or the egg, okay? You can resolve this by philosophical way, or you can ask ChatGPT and you can find the answer. There's two ways. Sorry. There's two ways and two explanations. What is first, the chicken or the egg? We have in the American Hernia Society our own ChatGPT. David said in 2016 in SAGES Congress that tension-free is the best option. Don't close the defect, okay? Then that's a statement, okay? Let's focus. What are the benefits of closing or treating large defects? May reduce the space of seroma, potentially decrease the chance of recurrence because we think that the mesh should have greater contact surface and lower chance to dislocate it into the defect. Let's see, those who think different argues say that may increase postoperative pain because nociceptive pain after the stitches and the risk of nerve entrapment, may increase the surgical time, may has risk of bleeding, and the risk of non-tension-free technique. In all the publications and reviews, the most common morbidity is the seroma, okay? And it's supposed to resolve after 4 or 6 weeks, okay? But not all the seromas resolve after 4 or 6 weeks. Maybe it takes much more time. Several surgical techniques have been utilized to avoid formation of seroma. None of these surgical techniques have been implemented as an addition to the standard laparoscopic hernia repair. We get the transcephalic fascia inversion and tacking. We have closure, the transversal fascia applicated with barbed suture, distal sac fixation, endoloop technique, and the freeband sealant. Let's see a prospective randomized double-blind study that compares closing versus not closing during defects. They compare similar groups, 30 patients, and 30 patients in each group, and 2 of 10 of them, the seroma doesn't resolve after 90 days. That is not 4, that is not 6 weeks, it's more than 10 weeks, okay? And about acute and chronic pain and recurrence, there's no difference. And this is level 1 evidence. This one was a comparative study and was the first study with a robotic platform, okay, by CATSI. The number of patients was graded, 87 for the pseudos application and more than 100 for the control group. The incidence of seroma, pain scores, and recurrence rate were similar. And what about seroma and recurrence? This another one has a systematic review and meta-analysis in 2023 by Pedersen. Yeah. After selection 4 studies, the first 2 conclude, okay, that there's a difference about the seroma, but there are studies with low quality of design. Let's focus in the last one, okay, for sure. This one is a double-blind randomized RCT trial that the serum is higher in the group that is not closed. But if you are talking about postoperative pain, yeah, and recurrence, there's no difference. Until now, we have talked about direct defects. Let's talk about large indirect sacs, okay? The discussion moves to the management of the peritoneal sac. The complete dissection of the sac increases the chance to have high morbidity. And if you transect the sac and abandon the sac, you have more chance for seroma, okay? Let's check this study. This review, we got 7 reviews, and let's focus in these 4, yeah? Especially the last 2 ones. One of them, Jorge Dice, and the other one was Lee. In both, fixing the distal transected sac to the posterior wall gives you the chance that decrease the chance of seroma. But I know that the universe of the patient is very low, nothing bigger to have conclusions. Several days ago, we got this posted by Professor Dice, a difficult case, two hernias, one big dural hernia and one indirect hernia. In both, in the left side, he treated the direct sac with plication, the transversal fascia, and inversion to the Cooper ligament with a stitch. In the right side, the distal sac was fixation to the posterior wall in the part far away from the nerves. His results are very good, and is one of the ways to resolve this problem. About the risk of recurrence, we are going to change this approach, and it's time to talk about that you have an increased chance to have recurrence in patients, smokers, obese patients, huge direct defects, huge large sacs, and SSI. This study, yeah, is a systematic study and review. The main objective was to see the recurrence between the 2 groups. Both groups are very similar. The universe is over 500 patients, and there's a lower rate of recurrence in the closure group. The second outcomes were very similar. And finally, the dark shadow behind the surgical treatment of the large inguinal defect is the risk of post-operative pain, okay? All the systematic reviews that have been shown to you during the talk, all of them, there is no difference in acute and chronic pain. In summary, postoperative pain, no evidence against, but we have to consider tips and tricks, okay? Yesterday, Conrad showed a video of Professor Chen doing a dissection of the direct pseudosac, and he shows how easy it is to attract a nerve, how easy it is to attract the vas deferens. But if you use a short bite stitches, maybe you can avoid it. About recurrence, variable results, so only consider recommendations, use bigger and heavyweight meshes. And about seroma, new data said that better avoid it, but it's not enough for a recommendation. But consider the local reality. It's not the same the reality in the United States than in Latin America than in Europe. I don't know, for example, in America, if you go for a bulk, and after 6 weeks you got the same bulk, the culture is different, go to another faculty. With ultrasonography that said you have some complication and you used to have problem, and all the patients got your WhatsApp number, always. It's different in Latin America. Other comorbidities, they do not play the game. I'm gonna show this post in EIC that if Cinderella should fit perfectly, then why did it fall off? It's not mine. I pick up from that. And this is a reality that we have to balance the data, the ability, analytics, experience, work, and get better results. Yeah, not necessary to get a statement. And my final answer for the dilemma, I can't answer that. But I'm gonna say that it's not wrong if you close it. Okay? Thank you very much.
Thank you, Dr. Alvarez. Since you're leaving, we can take any questions from the audience, if anyone has any.
I have one.
Yeah, please.
How do you do it?
Thank you for the question. I used to close all my defects, directs and indirects. Indirect sac, I used the same technique that Professor Diaz, I learned from him many years ago, and to fix the distal sac with a stitch in the upper part of the orificial, in the deep orificial, and in the posterior wall. And indirect defects plicate the transversal fascia without tension. That's the correct word, without any tension. Sometimes only plicated, sometimes if there's a very lax to the Cooper ligament. But what I treat is the space, okay?
Yeah.
What suture do you use for placating?
I use it both, barbed suture 3.0, and I used to monofilament PDS 2. In both are very smooth, but it's not the kind of suture, the way here is to applicate with very short steps, short bites.
Thank you so much.
Thank you very much.
Thank you, Dr. Alvarez.
Thank you, Alvarez.
Next is Raul Mahadar, talking about ETAP. We can go so far.
Good morning, all. Thanks for invite. And can I start? There is no disclosure. And greetings from Jivanshi Hospital, India. This is 79-year-old male patient with BMI 29, HbA1c 6.7, and he had supraumbilical hernia. Then he had post CABG incisional hernia. Then he had a iatrogenic Morgagni's hernia as well, along with incisional hernia and large inguinoscrotal hernia on the right side and small left side inguinal hernia. So he is suffering from 5 hernias together, and I want to give the only one solution for this particular all hernias. So the procedure of choice was the ETAP. We can go so far. I am Dr. Rahul Mahadar. So the steps of the operation, you can see this hernia, large hernias, and at the Horje-Dias point, 5 centimeter and 3 centimeter above the left rectorectus space is achieved. Then division of the posterior rectus sheath is done. And with these 2 instruments, we deal with the right side inguinal hernia first. And then for the left side hernia, another port is put. And then we deal with the left side inguinal hernia as well. And then we put a trocar in the suprapubic region. And from there, the optics is shifted here and bottoms up dissection is started. And then right side and left side limited TAR is done. And then the entire procedure is reinforced with the help of a mesh. So we have achieved this left retrorectus space. This is the division of the PRS. And then we put a trocar through infraumbilical region, and then we proceeded for the dissection in the Reeves stopa plane, towards the space of radius. Here you can see the inferior epigastric vessel as well. And here I'm dissecting into the fascia. So fascia is white, although always follow the white, you will be always right. And then I'm going towards this right side hernia, and the assistant is asked to give pressure from outside so that the contents are reduced. And then the sac dissection is carried out. You can very well see the cord structures. And I'm dissecting around the sac, try to get out the vas away, and trying to dissect the sac as much as possible on either sides. And then after that, we decided to transect this particular sac, as this is a very big sac. So we put a stitch over here and we ligated this sac after reducing the contents, and then the sac is divided. And while doing this dissection, there was small peritoneal rent as well. So that peritoneal rent is been dealt with the help of a catgut loop. So you can see here now the small peritoneal rent, and that has been closed with the help of a catgut loop. And then the other side, parietalization of the cord structure is carried out on the left side. And then after completion of this, to reduce the seroma, I've learned this technique from Professor Jorge Reyes, and they fixed this sac laterally, and then the suprapubic port incision has been done, and then bottoms up dissection is started. And this is on the left retrorectus plane I am dissecting now. And then we started dissecting up towards this supraumbilical hernia. And after doing the umbilical part, the supraumbilical hernia is reduced completely. And we try to avoid as much as possible the rent in the peritoneum during this particular entire procedure. So PRS complex is completely saved, and we are now approaching towards this post CABG hernia, and the hernia contents have been reduced completely. And after doing this dissection, we found that there is a Morgagni's hernia as well. So we have to be very cautious, because we have to be very gentle while doing this particular dissection. And then it was very difficult to get into the plane of the diaphragmatic muscles and the peritoneum here. So we have to be very slow and steady to do a dissection in this particular plane. So diaphragmatic dissection is carried out. Try to dissect the peritoneum away from the diaphragmatic muscles, as if this was a previously operated case. So slowly and steadily we achieved the plane, and then we did a right side transverse abdominis release, the bulky fibers that has been dealt with first on the right side. And then after doing this particular transverse abdominis release on the right side, we shifted our focus towards the diaphragmatic dissection. And here I am separating the Morgagni's hernia completely. And then the central tendon of the diaphragm that is dissected slowly and steadily, so that I should not make any rent over here, and that will be a disastrous situation. So I'm dissecting slowly and steadily towards this central tendon of the diaphragm. And then after completion of this particular dissection, then we shifted our focus towards the left side limited tar in the upper abdomen. The fleshy fibers that have been cut. And then after completion of this particular procedure, you can get the proper plane over here to put a mesh. So now we started reconstructing the midline linea alba. So reconstruction of linea alba is done with the help of a barb sutures. Here I am using 1 number barb suture, absorbable barb suture. And the complete reconstruction of linea alba is carried out. And after completion of this reconstruction of linea alba, then we put a 3D anatomical mesh on the inguinal side, on the both the sides. Is a 17 by 12 size large 3D anatomical mesh has been put. And then macroporous polypropylene 28 by 30 centimeter mesh has been put in this particular dissected plane. And this mesh is fixed at only one point at the center of this particular previous incision. And then the mesh has been unrolled, and then it has been fixed with the help of a cyanoacrylate glue. And This is the immediate post-operative on table after completion of the procedure, and this is on the 9th post-operative day. This is the picture. Patient was doing very well as of now. Thank you very much.
Thank you so much. That was really impressive, and you can do this even without a robot. I'm really impressed. So it's an honor to present the next speaker, Victor Radu from Bucharest, Romania, and he has taught everybody in Europe to do ETAP. So I'm very curious to hear what you have to say about that. Have we gone too far?
Well, thank you very much for the invitation. It's a great honor for me to be here. I was asked to prepare this presentation having the title, ETAP, Have We Gone Too Far? You can imagine that's very difficult or impossible for a great fan of this technique. For this reason, I have added, how it works, this is the reason because I have added the subtitle, why the answer is an emphatic no. Nothing to disclose. Well, this technique was published by my friend, Dr. Igor Bryansky 9 years ago. And you know, it is a very, very nice, fantastic, brilliant, even sexy technique, of course, in the hands of an experienced surgeon, offering excellent results. But at least on that time, Igor was very concerned about the future of his baby, because at the same time, this technique is difficult, it's challenging, it's skills demanding. And to reproduce this technique, it is not enough just to watch on Igor Belyansky's video posted on YouTube. Because, you know, it is mandatory to be familiar with the anatomy, to understand the anatomy, to identify and to protect some structures like neurovascular bundles, semilunaris line, linea alba. The principles, very well known, can be realized connecting three spaces, preperitoneal, retractus, and pretransversalis, crossing over the midline above or below the umbilicus. This technique can be performed robotically or laparoscopically. In robotic surgery, the key stages are the same. In this case, I would like to present a case with a hernia located in the lower part of the abdomen. It's a common a step to start to cross over the midline and to connect the both retractus spaces. Then I place my trocars just below the costal margin. I dock my robot and I start to cut the medial aspects of the posterior rectus sheath from cranial to caudal to connect the both retractus spaces. I reduce the hernia, and if it is necessary to perform a TAR, the robotic platforms offers a huge advantage, at least in this situation when the hernia is located in the lower part of the abdomen. I do bilateral TAR without changing the position of the robot. It's a single dock robot, and I start to do my TAR from cranial to caudal in Nowitzki way, cutting layer by layer the posterior lamella of the internal oblique, then the transversus abdominis, and after that I enlarge my dissection, my retromuscular dissection, as laterally as possible. In fact, exactly as I do in a laparoscopic procedure. Next step is, of course, if the hernia is located in the upper part of the abdomen, I change my position to be able to dissect behind the diaphragm up to the central tendon if it is necessary. The next step is closure of the posterior layer, then restoration of linea alba, and finally mesh placement, a large piece of mesh, polypropylene mesh, which covers the entire dissected area. Now, let me talk about these two extremes. I mean the small primary ventral hernia and the complex hernia. Because many surgeons consider ETAP an overkill in small ventral hernias, but we can adapt to this situation. Look at this case when the width of the defect is less than 5 centimeters. And considering the guidelines recommendations, we have to have an overlapping at least 5 centimeters surrounding the defect. To avoid overkill, I will place my first trocar in the upper corner. I develop the space exactly as I usually do. Then under direct vision, I place my working trocars medially to the linea semilunaris, and I start to cross over the midline, cutting the medial aspects of the posterior rectus sheath. I identify the contralateral posterior rectus sheath. I develop the contralateral retrorectus space. Of course, I reduce the hernia. And after that, I start to close the posterior rectus sheath. Of course, if the tension is not too high, then to restore nia alba, closing the defect. And finally, I will place in this dissected space only 15 by 15 centimeters my mesh. So we can fix these small primary ventral hernias without overkilling. Now let me talk about an opposite case. This is a very large incisional hernia, pararectal hernia with loss of domain. In this case, the volume of the hernia represented 40% by the restant abdominal cavity. Of course, I pre-optimized the patient with Botox, and my plan was to do a robotic ETAP. I started to develop the left retrorectus space using an optic trocar. Then I connected the spaces, and I placed my robotic trocars below the costal margin, and I dock my robot. I start to connect the both retrorectus spaces, and in this case, I started to do a right star, of course, after I identify the landmarks. And again, layer by layer, I cut the posterior lamella of the internal oblique, then the transversus abdominis. I dissect behind the transversus as laterally as possible to get a large overlapping of the defect. Of course, I reduce the defect and then I measure it. It is a large pararectal hernia, 15 by 15 centimeters. So a robotic platform again offered a huge advantage, because to close this large defect, I started to thread my sutures from 3 different directions, cranial, caudal, and lateral, like in Mercedes star, and then I dropped down the pressure down to 5 millimeters mercury to be able to tie these sutures. Of course, to maintain the space, I use the robotic arms as a lateral lift. I lift up the abdominal wall to keep my space, and then I place a large piece of mesh to cover my repair. Why ETAP is the best? This is the largest prospective study, and you can see a very, very few surgical site occurrences, very few recurrences. And this is my last publication this year, the experience after the first 5 years of ETAP. You can see the hospitalization was very short, less than 1 day, fast recovery, less pain, and I was able to fix even large hernia. And talking about complications, of course, there are some complications, not too many. 95% of all of my patients, around 200 patients, without any complication. So, in conclusion, ETAP, have we gone too far? Absolutely no. But please keep in your mind that this technique is not easy. It's a challenging technique. And to offer good results for our patients, it is mandatory to understand and to be familiar with the anatomy. And who knows, maybe in the future, this technique will become a gold standard. The future is unwritten. Thank you.
Thanks, Dr. Radu. Next is Benjamin Miller from Cleveland Clinic, talking about TAR as a means of anterior fascial reapproximation.
Hi, good morning, everybody. My name is Ben Miller, and my talk's going to be about whether or not the TAR advances the anterior fascia. Here are my disclosures. I think you saw them. So anyway, so there are 2 goals when we do a posterior component separation with a TAR. The first goal and primary goal is to make a big retromuscular pocket for wide mesh overlap of the defect. The second goal is, if possible, to get the anterior fascia closed over the mesh. So this operation has 3 myofascial releases: retrorectus dissection, dividing the posterior lamella of the internal oblique, and then doing the TAR with a wide retroperitoneal dissection. And the question is, does the TAR part of this procedure advance the anterior fascia? And this question has been looked at by 3 different groups. 2 of them were in Cleveland. One was at UH, and one group was in Wilmington, Delaware, the Novan Health group, or Wilmington, South Carolina, sorry. And then the other group was the Cleveland Clinic. We looked at this last year. So, okay, so we're going to look at these 3 studies and compare their outcomes. So the first one we're going to start with is the first one that was published, the one by the group at UH. So this was published in 2018, and this study looked at fascial advancement, not tension, but advancement. So it included 10 fresh cadavers with no hernias, but these authors made a midline incision and then attached a series of clamps on the fascia and hooked this up to a pulley system to which they could add increasing amounts of weight. So they started with 2.5 pounds, then increased it to 5 pounds, and then lastly they would pull on this pulley system with maximum amount of force that they could generate. And you can see in the figure on the right there, they marked the fascial advancement with these clamps as they did each one of these releases. So they measured fascial advancement in this way. And so let's look at their results. So this is fascial advancement with maximum tension, not the 2.5 pounds or 5 pounds, but maximal tension, okay? So the figure on the left is anterior fascial advancement, figure on the right is posterior. And let's just take a look at the amount of advancement that each of these releases gets you from a baseline. So they measured the baseline, right? So they made the incision and then measured the baseline advancement just by making a midline incision. So just keep that in mind. And then the other thing I'll say is that they added a 4th data point. So normally I think of this operation as 3 myofascial releases, but this group added a 4th data point, which is after they do the TAR, the 4th data point is the wide retroperitoneal dissection. Okay, so that's the bottom data point there. So okay, so here's the advancement you get on the anterior fascia with each one of these releases. So you can see that the maneuver that gives you the most advancement of the anterior fascia is the retrorectus dissection. Okay, let's look at the posterior sheath. So here's the advancement you get on the posterior sheath. You can see that the TAR with the retroperitoneal dissection gives you the most advancement of the posterior fascia. So anterior fascial advancement, the move that gives you the most advancement is the retrorectus dissection. And for the posterior fascia, the move that gives you the most advancement is the TAR and the retroperitoneal dissection. Okay, so next study, this is by the group at Novan Health in North Carolina. They looked at patients, so they had 25 patients in the study. They all had incisional hernias, and they did a TAR in all these patients. And this is how they measured the tension. So they didn't have a sterilizable scale or tensiometer, so they hooked coker clamps to the hernia's widest point, and then put scales in sterilized bags, and then hooked these scales up to the coker clamps, and then pulled on these scales until the fascia from both sides reached the midline, and that's where they measured the fascial tension. So this study didn't measure advancement, it measured fascial tension, okay? So, and they only measured it in 2 different places. So they measured the tension after the retrorectus dissection, and then they measured the tension after the TAR. And the TAR for them included dividing the posterior lamella, doing the TAR, and doing the retroperitoneal dissection. So they measured the tension in 2 places, and they found that they didn't measure the posterior tension either, just the anterior tension. So they found that the anterior fascial tension decreased the most, again, sort of like the similar study in cadavers, with the retrorectus dissection. And the TAR didn't give you much anterior fascial advancement in these patients. Okay, last study. This is our study we published last year. It was 100 patients, M1 to M5 hernias. They all had TARs. The average hernia width was 13 centimeters, so these are pretty big hernias. And this is how we measured tension on these patients. So we found the midline with a suture, hooked a clamp up to the hernia's widest point, then hooked a sterilizable tensiometer to this clamp and pulled the fascia until it reached the midline. And then you could read the tension in the body of the tensiometer. We did this at each of the myofascial releases. So we did it at baseline. We did it after we did the retrorectus dissection, we did it after we divided the posterior lamella, and then after we did the TAR with the retroperitoneal dissection on both anterior and posterior fascia. And here are the results. So on the x-axis, you have the fascial tension, the change in fascial tension. The y-axis, you have each of the myofascial releases. Let's look at anterior tension first, which are the orange boxes or squares there. So we started at a mean fascial tension of about 7 pounds, and this is just one side of the abdomen, not summed from both sides. So each side of the abdomen, so about 7 pounds, and you can see that on the anterior fascia, the move that gave you the biggest reduction in tension, again, we're measuring tension, not advancement. The move that gave you the biggest reduction in tension was the retrorectus dissection. And then dividing the posterior lamella gave you a little bit more reduction in anterior tension, but the TAR didn't give us much reduction in anterior tension at all. However, if you look at the posterior tension, the retrorectus dissection didn't give us much posterior fascial tension reduction at all. It was dividing the posterior lamella and doing the TAR with the retroperitoneal dissection that really brought that posterior fascial tension down to 0. If you think about this anatomically, it makes sense. So if you divide anterior structures, it gives you anterior fascial advancement. If you divide the external oblique or you divide the skin and soft tissue, that gives you anterior fascial advancement. If you divide structures that contribute both to anterior and posterior abdominal wall elements, like the internal oblique bifurcates to form the anterior and posterior rectus sheaths, if you divide the posterior rectus sheath, because it contributes to both anterior and posterior abdominal wall elements, you get advancement of both anterior and posterior structures. Like if you do the retrorectus dissection, it gives you some posterior and anterior advancement. If you divide the posterior lamella, it gives you both anterior and posterior fascial advancement. If you divide posterior abdominal wall structures, it gives you posterior abdominal wall advancement. If you divide the transverse abdominis muscle, it doesn't give you much anterior advancement, it gives you posterior advancement because it's a posterior abdominal wall structure. So in summary, this operation, the posterior component separation with TAR, advances both anterior and posterior fascial elements. The retrorectus dissection gives you most of the anterior advancement, and the TAR gives you most of the posterior advancement. I just want to say one more thing. Just because the TAR part of this procedure doesn't really give us anterior fascial advancement doesn't mean that we shouldn't do it anymore. We do so many TARs at the Cleveland Clinic. But remember, we're doing the TAR to make a big retromuscular pocket for mesh, right? And to do that, you have to bring the posterior fascial tension together without tension. If you have tension on the posterior fascia, then you end up, like if you were here for Will Hope's talk earlier, you end up with intraparietal hernias and posterior sheath breakdown. So we do the TAR to make a big pocket for mesh, to get wide mesh overlap, and to bring that posterior sheath together without tension. Okay, that's it. Thanks.
Great talk, Ben. Interesting study. Now I'm going to invite Dr. Sharat Sharma from Mumbai, India, and he's going to tell us what we need to know about DIEP flaps.
Thank you, Mette. So I'm going to talk about the unusual hernias that we have, that is the tram and DIP flap related hernias that we see in our practice. I have no disclosures. I bring greetings from a very wet and rainy Mumbai. Well, breast cancer surgery can be quite disfiguring and debilitating when it comes to the lady. But yes, breast conservation and autologous breast reconstruction has brought tremendous improvement in the aesthetics. There is good amount of patient satisfaction, there is long-lasting results, and they also follow the natural aging process. So it definitely gives good results. In fact, it also gives body contouring advantage. So whenever they are using abdomen-based flaps, they also do body contouring. We have mainly two kinds of abdominal wall-based flaps, and they are the transversus rectus abdominis myocutaneous flaps and the deep inferior epigastric perforator free flaps. Well, we need to know what they do, so it is something very interesting that I have noticed. Well, when they do the flap dissection, in the tram flap, if you see carefully, what they do is they harvest the rectus muscle along with the anterior rectus sheath, and they do it either unilaterally or bilaterally. And you see here in this video, they are carefully or in such way dissecting or incising the anterior rectus sheath laterally. And if you see in the last part, he's actually gone across the linea semilunaris. So this is one of the potential dangers of doing the surgery. In DIP flaps, they are harvesting the skin and the subcutaneous tissue with the pedicle of the deep inferior epigastrics. Here, it is a rectus muscle sparing flap, but they have to divide the lower vascular perforators, which again can be an Achilles heel for the surgery. There can be associated morbidities with this surgery, like patient can be obese, maybe a smoker, there can be previous radiation received for the breast cancers, patient can have additional abdominal scars of surgeries. And all this can add to the wound complications like the infections and flap necrosis, which can lead to poor outcomes. Now comes the problem. So we can have technical errors and we can have perioperative morbidities, which can lead to problems. There can be weakness of the core muscles, which can lead to a loss of sit-up strength. There can be problems of trunk rotation and flexion, so there's a disruption of core mobility. Over and all, there is a limited mobility or activity for performing heavy tasks. Along with this, there can be laxity. So there can be disfiguration, laxity, which can be generalized if there is a bilateral flap issue, or it can be asymmetrical abdominal bulge. And of course, the final could be a large ventral hernia. There are definitely surgeon factors when we are discussing this. So a poor knowledge of abdominal anatomy, which unfortunately is a reality when there is a plastic reconstruction. There can be lack of equipment. So if this surgery is being done in a peripheral hospital where a complex surgery like this requires more equipment, which may be missing. The primary aim of the reconstructive surgeon is to achieve a good breast reconstruction, and the secondary may be to reduce donor site morbidity and maybe do a kind of abdominal reconstruction. But to what level do they talk of abdominal, or are they thinking of the integrity of the abdominal wall? We are not aware of. There can be a disruption of linea semilunaris, as you can see in the figure there. There can also be a late muscle atrophy in DIEP flaps. You can again see it in the next figure, which can be due to the devascularization and the nerve damage during the surgery. There is also lack of clarity on how they close the abdomen. So they can do just plication without any mesh reconstruction, or they may use biological meshes. They may use polypropylene meshes as inlay. If you can see here in another figure, there is a large defect of about 15 by 30 centimeters, which has been repaired with 4 15 by 15 meshes as an inlay, which are just tacked to the muscles, to the lateral muscle linea semilunaris with a few stitches. So overall, there is an inadequate abdominal reconstruction, which may lead to poor outcomes. We have a real possibility of hernias after these flaps, and the incidences can be as much as 8.8%, which is reported, but the recurrent hernias can be as high as 20 to 70%. Now, the repair of these hernias have been described over the last 4 decades by all the major publications, which can be anterior component separation or posterior component separation, external oblique, or other muscle flaps. We can have dual meshes, onlay and inlay meshes. So there are various methods which have been described for repair of these hernias, but one significant repair, which is actually a primary repair of this, at the time of primary surgery, which has been described, and I would appreciate that if we can do this more often, that is a TAR, at the time of primary reconstruction of the abdominal wall, I think would be a good idea. This is a ventral tap for a DIP flap hernia, which I'm doing here. You can see the left-sided bulge, and it is a pretty difficult surgery. If you see, I have entered the abdomen, and you can see the bulge, and this is actually an external oblique on the roof. It's kind of an acquired Spigelian hernia. So I'm using Varies needle to insufflate carbon dioxide because there is no space there. It's an entirely fibrous tissue. After doing this, I will carefully raise the peritoneal flap, and you will see the difficulty during this part. Once I start incising, you see there is no preperitoneal tissue. There is no fat there. It's a completely fibrous area. 99% of Indian surgeons do not have access to a robot, so you will always see laparoscopic surgeries here. You can see those clips which in the fibrous region. We have to be careful not to buttonhole the peritoneum, because in that case it will be a disaster. I have reached the lateral border of the hernia, which is formed by the internal oblique and the transverse abdominis. On the roof of this hernia is the external oblique muscle. These clips can be either go with the rectus muscle or with the peritoneum, whichever is convenient. This is the dissection of the lateral border of the hernia, that is the lateral border of the disrupted linea semilunaris. Now, I have created enough space. This hernia measures about 5 centimeters by 9 centimeters, and I will be reconstructing it with a 2O barbed suture, which is delayed absorbable. This is done. I run in 2 layers so that I finish the thread and we give a good reconstruction. Here is the reconstruction done of the linea semilunaris. And I will be now placing a macroporous mesh of about 15 by 20 centimeters, fixing it and closing the peritoneum. So this is how it was done. Finally, I have some recommendations, mainly to the breast conservation surgeons, that they need to respect the anatomical margins, preferably doing muscle sparing surgeries and preserving the neurovascular supply. Primary repair should incorporate some kind of muscle reconstruction, if possible, with a component separation. They should use large meshes to cover these areas so that we have adequate, with heavyweight meshes rather, to have adequate strength, and also create a best possible functional abdominal wall. Thank you very much, and I invite you all to Chennai for our DI surge. Thank you.
Next, we have fistula management to stage or not to stage by Dr. Bormeester from Amsterdam.
Thanks for the introduction. Here are my, no disclosures, forgot them. Well, diverse, I can tell you. Management of enteric fistula. If you do it correctly, the patient from the photo on the left side with this problem goes to the right side photograph, and everything works out well. Just a quick recap for the acute type intestinal failure is a type 2, can be caused by infection, ischemia, surgery. This is an enteroatmospheric fistula, which creates a functional short bowel. Bowel's there, but it's not functional. Intracutaneous fistula could be exactly the same. If it's a short bowel, then there is an absolute reduction of bowel length, which will not come back. And some of these patients go from type 2 to type 3, becoming chronic because they can't hold their enteric autonomy. Now you have various levels of complexity in these fistula patients. Usually it goes fistula together with hernia. Just an example of a case, traumatic aortic disruption, surgery, abdominal wall dehiscence, mesh, created fistula, multiple codicutaneous and enteroatmospheric fistula. And he appeared to have Ehlers-Danlos type 4, which was not known before. We did a reconstruction, multiple anastomosis, 3 small bowel, 1 colonic anastomosis, and that is where the crucial part is. If you have these anastomosis, you have to close the abdominal wall, otherwise the anastomosis stand no chance, and the leak rate is very high. So since we needed skin flapping or skin flap rotations, this was an anterior component separation, bridging biomesh reinforcement, we did a total rotation full thickness on the right hand side, and then full thickness skin transposition called the keystone procedure, and then the hole on the left lateral side is filled up with a split skin graft and then totally vacked. So to go to the core of the question, to stage or not to stage, the answer depends, but it's not the dependent factor is in the surgery, because to stage surgery, no. It's a one-step reconstruction surgery, I will explain you. But there are different stages. There is the pre-op stage. Yes, you need that, prehabilitation. And there's the post-op stage. You need that too, because there's still post-op bowel adaptation, which takes a lot of time. So stage 1 is the prehabilitation of the IF patients. And we call that bridging to surgery, and it's very, very important. That may be the key factor why our mortality dropped to almost 1%, because we do prehabilitate and we delay surgery. So anabolic balance, physically and mental recovery. The abdomen becomes also more accessible, the number, depending on the months that have been passed. And that is linked to outcome, as simple as that. For the type 2, 3 intestinal failure units, there are not a lot in Europe. There are a couple. There's only one in the Netherlands that handles type 2 and 3 IF for adults and children. That's our hospital. So the complete package. So we also handle the chronics and also children. And there are 3 other centers that only do type 3. And it is important to keep up with all of the new developments, because there are many developments in this prehabilitation, but also in the TPN handling. And I used to be the lead of the intestinal failure working group of the European Reference Network, but has now been done by Mary Tabras, who is a pediatric gastroenterologist, and she represents us in that. So you focus in the prehabilitation on nutrition in case of the abdominal, enteroatmospheric fistula, enterocutaneous fistula, complete mapping and the correct terminology of the anatomy. The mapping is important. You see this type of fistula, and you want to know, can there be enteral feeding or oral feeding is what we prefer. So there is a complete mapping you do based on imaging and the operative notes, but which are usually very inaccurate or absent on the length of the bowel or where the fistula could be. So you need to know the functional bowel length when you measure that or when it's known, because you want to know the potential absorption capacity of the functional remnant. We do small bowel enterography or MRI enteroclysis if we don't know, if you just can't figure out from the operative notes. If it's like 1 meter or 150, there is absorption capacity. So there is two things that you have to view. There's feeding the gut, which is oral. Better than nasogastric tube feeding, because that doesn't give you any advantage. Low fiber, isotonic fluids. Don't tell the patient to drink more because it just flows out. And the basis of his homeostasis is total parenteral nutrition, and we do all of that at home. And that's feeding the patient. And to know what is possible, you look at this graph, just look it up. It's a very nice paper from Gigi Boy. Proteins and carbohydrates are actually absorbed very high in the bowel, in the jejunum. So if you have jejunum, you have a lot of that. Fat is much lower, but so you have some capacity. Output reduction, we have published this schematic way of doing that. PPIs and loperamide melts, and you add codeine if you need it. And if you do that with the type 2 IF, we use bridging to surgery of more than 9 months. You see from the first visit to the pre-op visit, most of these patients are at home, 93% has oral intake, the albumin increases, and that is linked to outcome. And also time. Mortality after 12 months, 0 to 3%, 12 after fistula has developed. And the recurrence rate, 3%. That's where we are now. Granulation tissue, you can have 12 months, but still granulation tissue there, and that is up to on top of the bowel, so you need to wait for scar tissue or help it with a split skin graft. Then there's the surgery. That is one-step reconstruction. It is completely visualized. It's segmental resection, double row anastomosis, and then hide all the anastomosis away from the laparotomy area, so you don't get a recurrence. You just hide it from and have it some peritoneum on top of it, and the number of anastomosis you weigh that against the remaining bowel length that you need, and you think about the functioning enterostomy. So if you then you need to close the abdominal cavity, because that lowers the risk of anastomotic leakage 4 times. So it's 4 times higher if you don't close the anatomical abdominal cavity. If you need, use mesh, but use no synthetic mesh. That's horrible. There is an exception for that you do 2 stages. That's when you have internal fistula outside, drain outside only via drain, so there's not a real connection outside, and the patient has a continuous low-grade sepsis. So true prehabilitation is not successful in the first. So first we do a loop enterostomy proximal of the fistula and do that via a local incision that has been marked on CT. So that's where a proximal loop is. And the second is then months later, the reconstruction surgery. So close the abdomen. We do biomesh, in our case, Ovitex, under tension transfascially, and so there is no tension on the midline. We don't do TAR. Not because I'm not capable of doing a TAR, we do that in regular cases, but that would create another layer, big layer, which also gets contaminated because everything's contaminated. Then post IF surgery, the bowel adaptation is stage 3. it takes a couple of months, some 2-3 years, before your mucosas with all its villi have increased to normal or even supernormal capacity if it's your bowel, and you have to take that time. And this is an interesting data from St. Mark's. If you do recontinuity surgery, survival increases. In the patients who have had the recontinuity surgery, those that achieved autonomy and enteral autonomy have a normal survival compared to the normal population. And that's good to know. So in summary, IF patients with TPN need specialty service. A multidisciplinary IF team, so refer to an IF unit for stage 1, bridging to surgery, stage 2, reconstitution surgery, including ab wall, and adaptation is regaining intestinal autonomy. Thank you.
Thank you so much, Marja. These patients are definitely the most difficult to treat, so thanks to you. Now I'm going to present Dr. Cristiano Klaus from Brazil, and he's going to tell us how about we reduce or abandon the sac in large inguinal-scrotal hernias.
Thanks for the invitation. Then the question is, which is better, complete sac reduction or primary or planned sac abandon? This is my disclosure. Complete hernia sac dissection is a standard step recommended usually for both open and MIS repairs. In the meantime, the abandon of the hernia sac is usually an approach just used in cases of difficult dissections, in which the surgeon faces with some kind of complication, such as bleeding or cord elements injury. And this extensive dissection can potentially be related with a high rate of postoperative complication like ischemic orchitis or serohematoma. In order to avoid this kind of complications, some authors have advocated the idea of a planned abandon of the hernia sac as the first step of a TAPP procedure, as you can see in these next 2 short videos. Once you have done the dissection of the content, we check inside. This is a large and fibrotic hernia sac. Then we're going to perform a circular incision. This is just to show that is a fibrotic attached hernia sac. We perform a circular incision on the peritoneum at the level of the deep ring. We just need to be careful with the cord elements that runs inferiorly, and also the inferior epigastric vessels that runs superiorly. As you can see, the middle part is usually the harder one because we do have this fibrotic tissue. This is probably related to the previous incarceration episodes. Then with that, we have completely abandoned the distal part, and we're going to perform now a regular TAPP by opening the flap 4 centimeters. And once you have done lateral and medial dissection, we quite easily reach the previous dissection, what make able to recognize the elements and also to avoid this extensive dissection. And the price that we need to pay is just to close this extra hole and close the flap at the end in a traditional fashion. Another one, this case, left side hernia, the sigmoid is stuck inside. Complete reduction. And once again, large inguinal-scrotal hernia, fibrotic tissue, incision in the peritoneum, circular incision, inferior, lateral and superior, easily, medial part a little bit harder. We need to be careful, especially with the vas that runs close by this fibrotic area. We can do by laparoscopic approach, as I'm showing here. We can do under robotic approach, much easier, there is no doubt. But the idea, no matter the tool that you have, we believe at the concept of doing the abandon of the hernia sac without any further dissection. And once again, we put a rule inside, 15, larger than 15 centimeters hernia sac attached. Once again, medial and lateral dissection, and like bingo, we make a patient with a large inguinal hernia in a patient without a hernia. Then we just need, once again, to pay the price of closing this extra hole. What is the main concern about sac abandon? The main concern about sac abandon is the seroma formation. On the left side, we can see conflicting results if you check it in the literature. On the left side, RCT and meta-analysis showing a higher seroma formation for sac abandon. On the right side, RCT, meta-analysis showing lower rate of seroma with sac abandon. What is the problem? In these cases, we're not focused just for inguinal hernias, neither for plant abandon. Then you need to check the data, and the first paper published focused on this group of patients was done by the Brazilian group led by Dr. Morel, and more recently, last year, we've published at Surgical Endoscopy not just the steps of the procedure itself, but also a cohort of 76 patients in a prospective evaluation in which the sac was larger than 7 centimeters, and we can see a short operative stay. Roughly 90% of the patients discharge out with less than 24 hours. We don't use drains. The drains were placed just in a few patients in the pre-peritoneal space, not addressed to the seroma, but in patients taking anticoagulant medications. And about seroma, on day 7, we have 29% of the patients presenting seroma. On day 3, 25, 1/4 of the patients presenting seroma. But you can see that in most of the cases, seroma is small just in the inguinal area. And after 3 months of follow-up, we can say that just 11 patients presented a seroma, if we can say that 11 is just a simple number. No one patient needed in this follow-up drainage or what else. We can't state that abandon of the hernia sac as a planned maneuver is recommended so far because the data is limited. Should not be indicated for all inguinal hernias, but we really believe that this approach in patients with large and especially fibrotic hernia sacs might have potential benefits. And the seroma appears to have the same benign evolution as the one that happens after complete hernia sac dissection. Thank you.
Thanks, Dr. Klaus. And last we have Pilar Hernandez Granado talking about mesh fixation and inguinal hernia repair.
Thank you for the privilege of the podium. I am the last speaker. Please don't go away. I promise that I am very, very, very short. I have no disclosures. As already all of you know, international guidelines for growing hernia management recommend that in almost all cases, any type of mesh fixation in TEP repair is unnecessary, and mesh fixation is recommended only in patients with large direct hernias and 3 AHS classification undergoing TEPP or TEP to reduce recurrence risk. If you are going to use fixation, a traumatic mesh fixation is recommended. The new guidelines, the new updates of these guidelines said nothing more about the fixation in inguinal hernia repair. If you look in the literature after the publication of these guidelines, you can find a lot of articles, systematic review and meta-analysis talking about the fixation or no fixation in this surgery. This one included 25 randomized controlled trial with more than 3,000 patients, and they don't find any difference in recurrence rate and in chronic pain, but early return to daily life in non-fixation group. This other one, including 80 18 randomized control trial in patients only with hernias, not L3 or M3, and fixation with glue or suture are excluded, and analyze the difference between non-fixation versus mechanical fixation. And they found no difference in recurrence rate, but less pain scores at 1 postoperative day and 6 months in non-fixation group. If you divide between TEPP and TEP, there is no difference again. Moreover, fixation increases the cost of the procedure because the devices are expensive, even glue. And why do we still fixate MS? Most surgeons think that all these works have a great heterogeneity, large risk of bias with a lot of confounding factors. And most studies came from selected group of surgeons with high level of experience in laparoscopic surgery. And more important, most surgeons did not follow guidelines because they don't believe in them. And on the other hand, there is low rate of complication with fixation. And surgeons must feel fear of recurrence or fear of legal issues in the future. And fixation makes feeling safer. As William Shakespeare said in Hamlet, in our hands is to fix or not to fix. That is the question. Why do you still fixate MS? I don't know. Really, I don't know. Perhaps we need to follow the guidelines. Fixation in large defects in medial hernias, automatic fixation when you need it, and no fixation in the rest. Thank you very much.
Thank you all for a wonderful session. We have about 7 minutes for questions. I'll ask the speakers to come up. Okay, we'll start with Dr. Al-Mansour.
Mazen Al-Mansour, University of Florida. Question for Dr. Meller. Great talk, by the way. So if your study showed that the TAR does not reduce the tension on your anterior fascial closure, and you're using the TAR still to provide the release of the posterior fascia so it's not closed on tension, why not use something like vicryl mesh or hernia sac? And if these were available to you, would that make you not do the TAR?
Yeah, that's a good question. And it's just that our bias is to close. I mean, hernia sac would be totally fine. You know, our bias is to not close with vicryl mesh if we have native tissue available to us. And we do a lot of these, and so we feel like we do them pretty safely, and we can easily extend out to a TAR if we need to. But we just published a retrospective study of people we had to bridge the posterior sheath with vicryl mesh, and it turns out that it seems to be totally safe. So you bring up a good point, but I think that the answer is we don't know. And it's just our bias to close with native tissue, so that's why we do the TAR to get the posterior sheath closed without tension.
TAPP, the mesh starts falling on you. There's nobody to answer.
Pilar had to leave, so I can't answer the question. Sorry.
Can I go ahead? So my name is Fadi Slade from Toronto, Canada. I have a question for Igor or anyone else on the panel, I guess, with regards to the closure of the posterior sheath. I've been doing, actually, I attended one of the courses like with you maybe like 8 years ago. So I've been doing it. I think I have the highest volume in Canada on, with ETEP. So you know, and I have fellows who close, and so have you noticed an increase in interparietal hernias or blowouts from closing the posterior layer? And secondly, I used to close the posterior layer until I felt there was just too much tension. I was scared of that tension, so I stopped doing it after my first or second year. And so what percentage can you not bring together? And what do you manage? How do you manage that? So those are two questions.
Yes, so it's an interesting question. And whenever I stand on the podium and talk about now, sharing what I do in my practice, closing posterior sheath, I'm certainly very aware and worried that people are going to start doing this and going to see increase in intraparietal hernias. I have not seen an increase in the parietal hernias myself, but I'll just, a word of caution, when you close this posterior sheath, you really need to know what to look for. It's a tension closure. I mean, everything that we do in abdominal wall is a tension closure. Even when you bridge with repair, it's going to be some tension at the points of fixation when you bridge. And so, I mean, it's a dynamic structure. And so, I talked about how to do this, dropping the pressure. So it's a producible. We haven't seen an increase, in the last probably 9 years that I've been doing reef stop repairs, whether it's bridging or not. We had about 5 incidences of intraparietal hernias. And usually it happens almost immediately as the patient is waking up. In my experience, what I found is, if say there's a portion of missing posterior rectus sheath and you close everything together, there's going to be a line of tension coming across that you'll see almost like the posterior rectus sheath erased. That portion, that point needs to be taken care of before you get out. So what I'll do is, I'll divide the posterior lamellar and turn oblique. And if it flattens out, great. But if I need to do a limited TAR, not a full TAR, but just a limited TAR just to decrease that line of tension. Again, I'm just sharing my experience here and understand that we're going to study this. They're going to look at respectfully to see how. All I want to do is emphasize understanding that perhaps, I disagree with Victor. I think we are overusing ETAP. There's nothing wrong with preperitoneal repair. There's nothing wrong with an IPOM repair if you do this well. This should not be done by everyone out there. This is a lot of difficult steps that are not necessarily reproducible by everyone, and we're going to see in general a lot of complications related to this surgery. So I'm of this opinion now. So we use it for medium-sized defects, but when do we do a TAR? A TAR is usually kind of for really large defects, and really Alfie Carbonell years ago talked about the relationship of the width of the defect in the relationship to the retrorectus space. And so if the width is larger than the retrorectus space, we typically, the rule of thumb is we're going to do a transverse abdominis muscle release in these cases. Hopefully that answers the question.
Good, we'll take your question.
Thank you so much for all the speakers. It was very educational. Samrat Muni from West Virginia. Regards to the speaker that talked about bilateral tram hernias, I find those to be one of the hardest hernias to fix because they've lost their core muscle. The rectus muscle is gone, right? So they, even if whether you do a bridging, you do a TAR, and you fix it, their core function never really returns. A lot of those patients never really had that discussion with their plastic surgeons about how their core is never going to be the same again. So should we as a society start having discussions with plastic surgeons instead of trying to fix it afterwards about how maybe they should get away from tram repairs, and if they're unable to do DIEP, then go for other repairs?
So, yeah, I think the last slide of mine emphasized on that particular topic, that we need to educate our plastic surgeons and breast. So most of the reconstruction is not even done by plastic surgeons. It is done by the breast surgeon himself or herself. And they are, they train themselves to do that part of the surgery. And to my surprise, I attended these surgeries and I was actually discussing with him, why are you going so close to the linea semilunaris? And his question was, what is linea semilunaris? So it is that amount of ignorance we are discussing. We need to educate those people. Absolutely.
Thank you.
Hello.
You're up.
Yeah. Hello, this is Srikanth from New Jersey. A question to the panelists. So what is the purpose, coming to the same question, what is the purpose of closing the posterior sheath that is not the strength layer? As long as you close the peritoneal holes, what additional, thing are you achieving to close the posterior sheath? My other question is, has anybody looked into, like, rather than doing big TARs, giving risk of all this, linea similaris, hernias and everything on, doing kind of a bridging mesh or something to compare, like extended TARs versus,
Because the whole point is either, if it's for a small hernia or something, yeah.
All right, so I'll answer again. You're changing the shape of rectus abdominis muscle when you do not reload the posterior sheath. It's clearly, we're seeing this in CT scan and morphology of CT scans. If you look at the before CT scan, you have a very rounded cross-section, like oval retrorectus space or rectus abdominis muscle. When you divide that invagination of here you have muscles, you divide the invagination and you load the muscles in, they flatten out. Now, as far as a hernia is concerned, if you only care about hernias, that doesn't matter, you're right. You won't get a recurrence. It's a beautiful procedure. But if you start thinking about what we're doing to the patients and about how they look afterwards, you have to at least talk to them that you may develop some bulging in the midline. What about function? There's so many things we don't understand yet. We don't have a typical way, even like we should really as a society talk about function, quality of life, and start objectively measuring it. Because there's, in the Cleveland Clinic, or actually Michael Rosen and Yuri Nowitzki about 15 years ago, they used a Biodex machine looking at the generation of force. We don't typically, it's a cumbersome machine, it costs about $25,000, and it's just not available in every center. But if we, at least I think we should start looking at it, and if we believe that it's not important to load this, we should have studies comparing to, for example, what is a force of generation. I personally, again, this is my personal opinion, when you bunch up the muscles together, when you advance linea seminaris closer together, I think it's going to be easier for them to engage the core as opposed to when the muscles flatten out. In TARS, when that happens, I mean, it's a different patient population. You just want to fix the hernia and give them a good quality of life. But when we're starting to do this for diastasis and smaller hernias, and you're saying you're going to fix the bulge from diastasis, you don't really fix you'll fix the midline bulge, but then you increase the distance between the linea seminaris, and the whole rectus abdominis muscle starts to bulge out because it has no posterior forces anymore when you don't really. So that's the purpose. I want people to think about it and at least kind of understand the consequences of dividing posterior rectus sheath and not closing it together.
The problem is, like, if we start closing the posterior sheath, I think we may have to do more TARs to get that, tension free.
So my point is, when you do a TAR, even though you close posterior sheath, you don't have those forces anymore. So TAR divides those forces, completely separates the posterior layer from the underside abdominal wall. So when you do a TAR, you don't fix it. You have that the forces, the posterior forces on linea seminaris pulling in, allows it to invaginate. When you do a TAR, the muscles flatten out. So TAR and a restop a dissection without loading on a CT scan will look very similar when you look at the retrorectus spaces. They both flatten out.
Thank you.
So
I think we have time probably for 2 more questions.
So it's so my question, my remark is to Igor. When you reconstruct the posterior rectus sheath in your hands, it works perfectly well. But your words have a weight. So when Igor starts to close the posterior sheath, everybody starts. And I mean, the quality of closure is not the same in the hands of everyone. When they have a tension, then afterwards they start to make TARs. And from simple hernia, we go to a double TAR, and it makes a little bit of confusion.
And that's perhaps why I think, as I said, ETIP is way overused, and for simple hernias, we have to start considering and teaching that it's okay to do eye pumps and preperitoneal. My go-to is preperitoneal repairs nowadays for simple ventral hernias, and if we need to tighten things, that's it. Well, there's no reason, I don't do ETIPs as much as I used to because of the learned experience, and that's what I'm trying to emphasize here. Do not go for ETIP access. There's other ways to keep the mesh in extraperitoneal space. A simple tap repair will achieve that as well.
Okay, thank you, everybody. Thank you so much for some very interesting talks, and everybody give the speakers a big hand.
Okay, so we're going to get started with the business meeting now. Thank you for all of the people who have kind of stayed. So we do have some slides for this, I think. Do you have those? Okay, I'll give you one moment. In that one moment, though, I think this would be a great time for us to take the